It is my real privilege now to introduce Nadine Wathen, who is the full professor in Health Information Science, the HIS program in the Faculty of Information and Media Studies, also a research scholar at the Centre for Research in Education on Violence Against Women and Children at the University of Western Ontario in Canada. Nadine is going to present to us on recognising and responding safely to family violence, lessons from Canada, and I think we're so privileged to have Nadine here with us today. Thank you.
Good morning, everyone, and thank you for having me. Thank you for the welcome to country. Very much appreciate that. And to the University of Melbourne for making the trip possible for me to come all this way. So I'm at the point of my jet lag now where I'm not quite sure what words might come out. This morning I tried to say artichoke and I said avocado instead. So if things sound a little bit weird, then just sort of wave. Kelsey's my prompt off to the side. That's right. If it's really going off the rails. So I'm delighted to be here, and thank you to the meeting organizers as well for asking me to come. I was sort of reflecting on this at about 3 or 4 a.m. as I lay awake last night and thinking, you know, what is it that we can bring from Canada to Victoria? Because I think you're known as leaders in this area. I mean, the amount of work that's been done in Victoria over the last few years is really remarkable. So hopefully I can bring a little bit of insight from some of the things we've done in Canada as you continue to evolve the process and sort of roll out those 227 recommendations. So thank you to you for really doing this work and being an inspiration to the rest of us. So hopefully all the technology works. So I will speak today on recognizing and responding safely to family violence. Whoa, it buzzed. Did it work? Okay. And really what I'd like to talk about is a project that we call VEGA, which stands for Violence Evidence Guidance Action. And as I sort of think back, we're in year 5 of a 3-year project, so one of the lessons learned will be that this sort of work does take time, and you sort of expect that. And really sort of talk about the things that are making this project successful that might be lessons that can be integrated in the work that you're doing here in Victoria. And then some of the follow-on and related activities that we've undertaken to embed the work into systems and into hospitals and other health services. And hopefully, again, you know, provide a little bit of insight and leave some time for question and answers. You folks run early, which is fantastic. Well done, Liz. So I'll take all the time that I need. So I think it's important to start a little bit with some of the things that were precursors to the VEGA project and the importance of sort of giving things time to unfold around these complex and I would say even wicked problem areas. I talk about gender-based violence and violence against women as a wicked problem because not only do we not understand the solutions straight away, but as we sort of move towards solutions, the problem keeps moving around and changing. And it's so interrelated with other problems. So I also do work in the area of health equity and health inequities, and just the interrelationship between trauma, violence, racism, discrimination, opioid misuse, and so on. These are all interconnected problems, and it is, you know, it does take sort of a village, I guess, to get to the point of having some responses to these problems and understanding them in their full complexity. So when I think back, and actually the slide that I created and sent didn't have the first bit of research that we did to uncover this problem, which started in the mid-2000s. And as you will all know, I call this the emperor's new clothes problem. There was a sort of push for health providers to provide a consistent, meaningful, safe response to victims of violence. Yet when you started to sort of look underneath the hood a little bit, you realized they're not getting any training to do this work. So we actually undertook a project in the province that I work in, Ontario, which, you know, has about 10, 11 million people, so it's a fairly large province. It's probably fairly equivalent to Victoria. And we looked at over 200 different professional programs, both pre-service, so undergraduate nursing, undergraduate medical education, and so on, and continuing professional education. And we found that it was really inconsistent, if you know, ranging from nothing to maybe, you know, some education that these learners were receiving on the topic of intimate partner violence. So how are people supposed to provide a safe, knowledge-based, evidence-informed response if they're actually not being educated on this. So that was sort of the first learning, is pushing back a little bit against this problem, this mismatch between what people expect and what people are actually prepared to deliver. So does that resonate with folks? I see some heads nodding. Okay, so it may be similar here until the more recent work started. So the next thing that happened is this opportunity to build on existing relationships, and I think that is another key theme. I like to give away my key messages as I go. The importance of relationships between researchers and policy and practice folks, and researchers with one another, and so on across different sectors, and just the importance of building on relationship. So we have a research network called Prevail, Preventing Violence Across a Lifespan, and Kelsey is one of the founding members of Prevail, so it's been about 10 years for Prevail. We're actually just winding it down, but I can speak about that later. One of our main partners throughout the course of Prevail was the Public Health Agency of Canada. So that's a federal level agency that is tasked with all sorts of domains of public health, from infectious disease control, chronic disease prevention, mental health addictions, and so on. But they also have as a priority family violence. So that's part of the public health portfolio, which again speaks to the importance, as the minister was alluding to, of embedding this topic into the thinking of health systems and healthcare. So it was 2013, so the paper around the lack of education for providers was published in around 2009 based on data collected a couple of years earlier. 2013, at the World Health Organization Milestones meeting, I had a chance to speak with one of the people from Public Health Agency of Canada, because you have to go to Mexico City to speak to somebody from Ottawa when you're from London, Ontario. That's how it works. And she said, well, what would be the number one priority in terms of really enabling a better response to victims of violence? And I said, well, the emperor's new clothes. I mean, we need to actually provide fundamental education across health and social services for people responding to violence in a safe way. So that little conversation actually led a couple of years later to the opportunity through an initiative announced by our federal government, and this was actually a Conservative government in Canada, and another theme I think I'll reflect on is the theme of opportunism, and opportunities sort of arise very suddenly. This was a government at the time that did not pay a lot of attention to this issue. However, a health minister came in who cares passionately about violence against women. So she ensured that $100 million was invested and embedded going forward in the system, regardless of changes in government. So that was a huge opportunity to do some of this work. And the folks, I think there was one person left at the Public Health Agency and Family Violence at the time, basically said, reflecting on our conversation, that this education piece is extremely important, that we will not have a coordinated response until we have fundamental education. So, from there went the grant writing, because we always have to write grants, and thankfully funding received. And then again, this health minister at that point saying, okay, my main intervention now, having established this investment, and we did not get $100 million for the project, by the way. We were just the first of many projects that are still rolling out across this. But the health minister invited health and social service national level organizations to come to the table to guide our project. So that was incredibly important, that we have 22 national organizations that actually have worked with us throughout this project to create the guidance and curriculum that their learners will need across their learning experience, from pre-service through to folks who have been in service for many, many years. So, that way. These are the 22 organizations. So I'll just sort of leave that up, because you'll see the breadth of types of providers represented here. Certainly, many of you in the room will sort of resonate with the healthcare providers represented here. But we have the Mental Health Commission of Canada, for example, Women's Shelters Canada, the Child Welfare League of Canada. I don't know about here in Victoria, but in Canada, if you can get the shelters and child welfare in the same room talking about something nicely, that's quite actually an accomplishment. So Royal College of Physicians and Surgeons is important because they accredit specialist medical education in Canada. The College of Family Physicians accredits family medicine education. The Canadian Association of Schools of Nursing accredits undergraduate nursing education. So you start to see that we had people at the table guiding the work with us who can actually have an impact on it becoming embedded in the systems where it needs to be embedded. So this was extraordinarily important. I'm not sure how closely you work with dental providers here as part of this work in Victoria, but that was sort of a revelation to us how keen our partners from the Canadian Dental Association and the Canadian Dental Hygienists Association have been to do this work. In fact, we had a meeting, we had 3 hours on a national agenda on family violence to speak to a whole range of oral health care providers. So again, these opportunities through this work, probably what makes a 3-year project into a 5-year project, but I think are invaluable in terms of starting to see how this gets not only pushed out, but embedded into those systems. So really, I do want to, just shout out, I guess, to these organizations for sticking with us for this many years and sending representatives and really doing the work alongside. And this gets me to my point around what I call co-production of knowledge. As we did this work, and to authentically engage with partners, not just to sort of show them a product and say, can you sign off on this, but to really sit down together and say, what is it that you need to be able to do this difficult work? What does the nurse in the hospital setting need? What does a shelter worker need to know about child maltreatment, for example, that will actually push the field forward? So we had to establish parameters. I think that's a really important part of developing a trusting relationship, is really being clear about the work that you're doing together and talking that through, because there will be sticky points. I mentioned child welfare and shelters. They just don't see some things the same way in terms of protection of women and children. So sitting down together and talking those things out is extraordinarily important. So what does this mean for our Vega project? Well, we started to flesh out some of these, what I'm calling development principles. So again, funded by the Public Health Agency of Canada, we took a public health approach to understanding violence and its impact across the lifespan. So an important piece here is the puzzle pieces. Okay, so we define family violence for the Vega project as including child maltreatment, intimate partner violence, and children's exposure to intimate partner violence in the home. So these 3 interlinked pieces have to stay at the forefront of our curriculum development and guidance development all the way through the process. And again, what the model is also showing us is that the Vega project is situated in the secondary, tertiary prevention zone. It's not about primary prevention. It's really, once people have been exposed to these forms of violence, how do you prevent that from happening again? And then how do you prevent the short and long-term consequences of those exposures? Okay, and from a health perspective, it would be sort of health outcomes of those exposures. So that sort of gives you the model, and we discussed this, with our national committee. We call it the National Guidance and Implementation Committee, to make sure everybody's on the same page in terms of the model that we take. And the issue of both lifespan, that sort of exposures earlier in life will cause consequences throughout the lifespan, but also the intergenerational nature of violence. I always say you live what you learn. If you grow up in a household with violence, you're more likely to grow up to be a perpetrator and or a victim of violence, because that's the situation you're immersed in. And then what we call an integrated knowledge mobilization approach. So again, that's that notion of partnership and relationship with those 22 organizations, and then with others who we brought on for particular forms of expertise to make sure that we're all tracking in the right direction. And I think another really important point emerging from some of the discussions early on is that what we're trying to create was foundational guidance and curriculum. So really telling people, we're not trying to make you, the emergency nurse, an expert in family violence. We're trying to give everyone a common, initial, safe response to family violence, to people who are coming into your service and might be experiencing these forms of violence. So it's not about creating experts, it's about providing a common approach that will help those exposed to violence. So I think that's also it sort of settled people down a little bit, because people say, that's not where I want my expertise to be, that's not my role, but sort of understanding that everybody can do this with the right training, and it just builds on the skills that you have as a nurse or a social worker or a dental hygienist, et cetera. So that's a really key piece as well. And then at our first meeting, so I have a few of these slides that have the thought bubbles, but at the first meeting we had, which I was thinking back was sort of 4 years ago this month with these organizations, we put it all on the table. So basically said, what will you need to be able to, work with your membership? So these are national level organizations, many of whom would have provincial level or state level chapters, and they'd have to sort of move that knowledge down to that level, or universities that they work with through accrediting undergraduate programs and so on, as I mentioned before. So what would you need to be able to do that work? What are the barriers to practice from where you're sitting? I guess is a simple way to look at this. And we had a lot of discussion, and I've just sort of surfaced a few key points here. So what are the basics? What do providers need to know about violence to be able to do this work? That's sort of a big question. How do you actually get those real-world practice skills? Okay, so in other spots we refer to competency-based or skill-based education, which seems to be the way that we're going in Canada with many of the curricula that we have. I'm not sure if it's the same here, competency-based or skills-based education. How do we, as individual providers, engage with individual clients or patients around this topic? Like, how do you get past that difficult initial point to start having that discussion? How do you do so safely? So here I've sort of place-held this notion of trauma and violence-informed care. I'll talk a little bit about this later, but really preparing people to understand the impacts of trauma and violence across the lifespan, and that initial conversation that you have with somebody, and it may be the first time they talk about it, is extraordinarily important in terms of their desire to seek further help, if that's what they're ready to do, or to even come back to your health service. If it's not handled well, they may never come back to your health service. So these sorts of things were surfaced at the first meeting. And then when we talked about barriers to practice, what came through loud and clear was either discomfort, misunderstanding, or just general fear of those justice and legal system obligations, especially mandatory reporting. So you'll remember we have 3 puzzle pieces, including child maltreatment and children's exposure to intimate partner violence. Now, in Canada, most jurisdictions will have, all jurisdictions will have child maltreatment as reportable. And in most jurisdictions, exposure to intimate partner violence in the home is also reportable. Not so much intimate partner violence, although there have been some moves to try to make that happen. Is somebody going to sing? You have to sing the Canadian national anthem when it happens. What's that? In French. You have to sing the Canadian national anthem in French. I won't make you do that. But so does that resonate with this audience, this sort of fear or lack of knowledge about mandatory reporting obligations? That certainly was such a powerful message at that first meeting that we built a whole new part of the project around it to be able to address it. We had expert lawyers come in. We did an entire new systematic evidence review around that topic to really get a handle on it and give the best possible guidance and integrate it into the materials that we've developed. So really that lack of understanding of how these systems work, what happens once a patient or client goes into the judicial system, what happens in terms of policing and so on. I think an ideal project would have police and lawyers and judges on this national committee, but you sort of have to draw the boundaries somewhere. And now, the work will be to try to push some of this learning into those systems. How do you coordinate across different systems? I think that's some strong work that you're doing here in Victoria, trying to understand how to coordinate. And just issues at the micro level around how do you document the interactions that you've had with people so you're not doing more harm in terms of subsequent reporting, but that you are documenting things that will be useful once it gets to the point, if it gets to the point of legal proceedings. So those sorts of questions, it almost, if I describe the meeting, it was a room maybe not quite this large, but became the dominant theme of that meeting. It was very clear to us that we were not going to really do what our partners wanted us to do unless we really dealt with this and did it in an authentic way. And then issues around, feasibility and system factors. So it's one thing to say, we found pretty good evidence that cognitive behavioral therapy with a trauma focus can be beneficial for children who've experienced child maltreatment or intimate partner violence. But what if these services aren't available? What if you live in a very remote area? Or what if you can't afford these services, right? So again, sort of understanding accessibility, affordability, equity, these sorts of considerations at a macro system level, but also also, again, more micro, people are saying, well, what happens if there's not a quiet private space to have the conversation? You know, I work in an emergency department with a thin curtain. Should I even talk about it? So we had to start thinking, how do you give guidance across a range of service settings? Again, thinking of those 22 organizations and the different places that people might practice, to address the concerns that people have on the ground, to do their best to do no harm and to provide the best possible care. You know, training, again, that question of the emperor's new clothes, do people actually have the training? How do you motivate people against that feeling of Pandora's box? You know, if I go here, it's going to open Pandora's box, and I don't know what to do, and I don't know how long it'll take. You know, another piece around time. If I only have 6 minutes with a patient, if I work in a family practice, how does that even happen in 6 minutes to have this conversation? And then a question from our educators. You know, undergraduate curricula are already packed full. How do you get new content into curriculum? So all sorts of questions being surfaced at this meeting. And then, you know, again, this is sort of near and dear to the work that I do, these equity considerations. So how do you make sure that you're developing a curriculum and guidance that really pays attention to those who are facing marginalization in different ways and the intersections of different forms of marginalization. So you can see some of the issues that were brought to bear here, certainly mental health and substance use, our treatment of Indigenous peoples in Canada, and how to ensure that we weren't, again, further marginalizing folks through this work. So these are some of the things that came up, and they challenged us to integrate these considerations into the guidance and curriculum that we were creating. So all of a sudden, you know, we went from, again, a 3-year project, we'll develop some sort of tools and guidance, to something that, if we're really going to meaningfully tackle it, was going to be much different than we thought in the first place. So I like drawing little diagrams and things. So this is my way to sort of get at how Vega started to become shaped through these initial discussions with our 22 national partners. We had to be evidence-based or evidence-informed. I'm not sure evidence-based actually is possible, so evidence-informed, let's say. So we did systematic evidence reviews, and this was where having our Prevail network of researchers, research experts, was extraordinarily important. So on our Intimate Partner Violence Evidence Review Group, we had Kelsey Hegarty come to Canada to work on that group with us, and we did systematic evidence reviews for all 3 of Vega's topics represented in the puzzle pieces, using the GRADE methodology. I'm not sure if people are familiar with that methodology, but I think we selected it because it goes beyond the traditional sort of guideline development process or systematic review process, where often you don't find a lot of evidence, especially in these complex topics, and you end up with, well, there's no evidence to recommend for or against, and it's sort of, and practitioners go, yeah, but what am I supposed to do? I still have to do something, and you've told me that the evidence base is not very persuasive. So the GRADE approach allows you to consider things like acceptability, access, equity, and the sorts of factors that might tip the scales one way or the other in terms of actually being able to make a recommendation or provide guidance in these areas. So we use the GRADE method with our evidence review groups, and then we sort of collated all that evidence and brought it to our national committee, and worked with them using, again, a modified GRADE process to think through these equity and access issues, these acceptability issues, and so on, and to really develop core guidance that reflected the values of our common group, as well as what was available in the research evidence. So that seemed to be the best way to get to what do you actually do in practice, rather than some of the practice guidelines that we've seen that really just summarize a lack of evidence for specific actions. So that was sort of the core piece. That took about a year or 2 at the beginning. We also created what we call leader tables. And again, this was an approach that allowed us to really have our partners take a key and active role in developing this knowledge. So because we'd heard so much about mandatory reporting at our first meeting, we created a separate work group or leader table around mandatory reporting. And we brought them sort of legal resources and other things they needed to come out with a position on mandatory reporting and a way to integrate that guidance into the broader guidance around child maltreatment and children's exposure to IPV. We had a second leader table on trauma and violence-informed care. So again, thinking about those equity considerations and how to do no harm while promoting benefit, especially for groups that are marginalized in different ways. And then a third leader table on how do you actually develop all of this into education and curriculum and make it useful across the range of different providers that I mentioned. So types of providers, but also everything from your first or second year undergraduate through to your family doc who's been in practice for 40 years. So when I think back, I think we probably were maybe a little ambitious taking this on, this sort of the breadth of what emerged. But working with these partners and having them involved in these processes was necessary to, I think, to get to where we are now. And again, drawing in our experts from our Prevail network or elsewhere when we needed that sort of guidance. We also did environmental scans. Certainly we had the ethic of not duplicating work that's already been done. So let me get this right, Kelsey, the White Book, the Royal College of GPs here in Australia was one of the resources that we looked at, the WHO's clinical handbook on intimate partner violence, violence against women. So those are the sorts of resources already available that provide really good knowledge. Why would we duplicate those rather than sort of build on them and integrate things that might be specific to the Canadian context? So we really did quite a fulsome job in terms of gathering knowledge, but also creating knowledge with our partners through these leader tables and through the National Committee. And then the sort of end product is these competencies, an online handbook, and then a curriculum. So I'm going to show you a video.
Hi, I'm Maria. I'm a family doc. I think I'm pretty compassionate. I read the literature and keep up with what's new and the best practices for my patients.
And I'm Mark. I'm a social worker. It's important to support my clients and advocate for their needs. That's why I was so surprised when I became more aware of the huge impact of this one exposure. This kind of exposure is linked to all kinds of mental and physical health problems like depression, anxiety, alcohol, and drug use.
In children, it can affect how brains grow and develop and can lead to all types of problems across their lifespan. In adults, it actually increases the chances of heart disease, cancer, and other chronic illnesses.
It's not a toxin or a virus or a pollutant. It doesn't discriminate. It can affect everybody across all cultures, communities, and income brackets. The kind of exposure we're talking about is family violence. Family violence is a complex issue, and every Canadian family is susceptible. The numbers are staggering. About 1 in 3 Canadians has experienced abuse before the age of 15. A Canadian woman is killed about every 6 days by her current or former partner. We're becoming more aware that men are at risk as well. Transgender people have much higher rates. Over 60% reporting experiences of intimate partner violence, or IPV. You may know IPV as domestic abuse or domestic violence.
There are lots of different words used to describe family violence. With children, it's often called child abuse and neglect or child maltreatment. Another type of family violence is called children's exposure to IPV and involves a child hearing or seeing violence among caregivers or being aware of its effects without actually witnessing it.
Whatever you call it, research shows that physical, emotional, or sexual abuse and neglect can impact all aspects of a person's life, including how they learn, speak, behave, and interact with others.
When I read about family violence, I realized there was more to it, and I really needed to learn a bit more about this. I found a great resource called the VEGA Project. VEGA has created evidence-based guidance, a handbook, and innovative educational resources about recognizing and responding safely to family violence. It's the first time that national organizations, including nurses, dentists and dental hygienists, doctors, child welfare advocates, and a range of others have come together to develop ways of helping people know how and what to say and do to help patients experiencing family violence. Also, what not to do. This type of violence is not always obvious. In fact, it's often hidden. Most importantly, I don't want to do more harm. To be honest, I didn't see this as part of my role. I basically viewed family violence as a personal or social issue best addressed with a referral to someone else. Obviously, if there was a disclosure of violence, I would address it, or if it was a child protection issue, I would report it. But in terms of my patient's own personal medical history, I didn't consider how these experiences of family violence could impact their health.
I know what you mean. Although I learned about family violence in my training, I didn't learn about the widespread health impacts or how best to respond. Vega has developed guidance so we can better navigate family violence and how it affects our clients and/or patients. It makes me better at what I do.
Exactly. When I didn't consider how family violence influences disease and behavior, it prevented me from effectively communicating with my patients. Now that I really think about it, maybe I avoided bringing these sorts of things up because I didn't want to make it worse or shed light on an issue I couldn't handle. I didn't know how to make it safe to address family violence in my day-to-day practice.
The Vega Project developed an approach called Recognizing and Responding Safely to Family Violence, which addresses those exact concerns. Now, I feel like I know what I'm doing. I'm less worried about causing harm. And you know what? This is relevant to all my clients, not just those affected by family violence.
Very true. It makes me think more carefully about the cases I find challenging. I used to ask myself, why would someone act like this? Now I try to be more compassionate. So instead of wondering what's wrong with this person, I think about what's happened to this person and start the conversation there. Vega's handbook helped me to respond to my patients, and now I understand how important it is to create both a physically and emotionally safe environment.
It's encouraging, right? And new evidence is emerging about promising interventions that can help both adults and children address the impacts of violence.
Knowing how to recognize and respond safely and what the appropriate referral pathways are creates a better experience for all of us. When this becomes a part of your everyday practice, your patients are more likely to benefit.
To make this part of your practice, start by looking up projectvega.ca. There you can find tips and tools like how to recognize the possible signs of abuse and ways of responding safely. Practical, evidence-based guidance.
The Vega Project is available to educate and support us to work safely and effectively with those impacted by family violence. Vega helps us provide the best possible care for our patients and clients.
So that is a little introductory video that we did to orient people to Vega. What did people think? Yeah? Okay, good. It took a long time to write the script. And keep rewriting the script. So so that is a way to get across a lot of what I've spent the last little while explaining in a sort of five and a bit minute video to really orient people who, again, hopefully, regardless of where you sit professionally, that would resonate with you. And having two different types of providers do the narration hopefully gets that across. So another one of my diagrams here, I wanted to just sort of break down a little bit more of what's involved in the Vega resources. Again, because of the broad range of different types of providers, settings, and also geographic locations, we really went with an online approach. There's really no other way to do it. But online with things that we will develop in sort of our subsequent follow-on activities that could be taught in the classroom, for example. So a facilitated instructor guide, that sort of thing, to use the online tools in group-based work or in classrooms. But essentially, and work done by our education leader table was coming up with a set of core competencies. That was extremely important because then everything that we produced in terms of tools and other resources is built around these competency domains. And an important consideration, as I mentioned before, for example, in Canada, medical education has moved to competency-based curriculum. So in order to be accreditable, we had to produce something that was competency-based for the Royal College of Physicians and Surgeons to be able to do that accreditation. And similarly with nursing. Some of our groups don't have formal accreditation, but the competency or skills-based approach was resonated across our different groups in terms of something that would be very important. So we have these four different domains. The first is, and these are now translated into e-learning modules. And if you go to projectvega.ca, you won't find these right now. I'll give you the update on the timeline towards the end. But the first is really that understanding of the prevalence impacts of family violence. And in that module, we keep those three puzzle pieces intertwined. Okay, so that's important, that sort of development principle around a lifespan approach is understanding the interrelationship between these forms of violence. So that module is about those three forms of family violence. And then the second is starting to get at how to recognize and respond safely, which then sort of seamlessly leads to the third, which is facilitating referrals and sort of next steps for action. The fourth domain is really about what I mentioned before, the trauma and violence-informed care, that sort of planful approach to prioritizing safety based on awareness and understanding of the impacts of trauma and violence across the lifespan. And principles include things like collaborative, strengths-based choice and decision making with the patient or client. So understanding that not everybody has the same choices, and just giving everyone a menu of the same choices is actually inequitable. It will increase health inequities. So really trying to give people a sense of those principles and how to have discussions with patients and clients around options that would be relevant for them. The other piece of that actually, and we alluded to it a little bit in the video, is keeping the provider safe as well, and then taking a more structural or organizational level approach. So we have guidance to organizations about how to make sure that their providers are protected against things like compassion fatigue and vicarious trauma. Because the more safety you create for patients and clients to talk about these issues, the more you'll hear about them. As you know, everybody's nodding their heads. And therefore you need to not only do self-care. I think it's easy for us to say, take care of yourself, we'll put it in a little quiet room and you can go and look after yourself. But to really emphasize the need for organizations to do that support work, to provide employee assistance programs, or to provide facilitated supervision or reflective supervision so that people are supported in doing that work. So always we talk about the sort of the interplay between the individual level and the organizational or system level to support providers in doing this work and to create those conditions of safety. So principles like create a welcoming environment where people feel comfortable to disclose. That might mean, and I think of an example, speaking with people in child welfare, that because many of our Indigenous Canadians went through the residential school process in Canada, they changed the lighting because they were told by their Indigenous clients that industrial lighting was very triggering. So they would actually be triggered while waiting in the waiting room, which does not lead to a good interaction once you've gone in for your appointment. So they changed the lighting. So that might be have some cost associated with it, but putting up signs in multiple languages to make those that you serve feel welcome, making sure that people know how to get to the toilet and that if it's locked, where to get the key. These are things that just make that experience much better. Or providing coffee, tissues, those sorts of things. So there are some low-cost ways to create that feeling that people are welcome and that they're safe in your care. So that's really important for us as an overarching sort of framework to doing this work. So it is integrated through all of the different materials. Each of the sections, for example, in our handbook starts with creating a safe environment before you even get to how to identify, how to respond, and so on. And then, we've got the e-learning modules that are based on these domains, but also an online handbook. So people can just sort of download a PDF or go through just a how-to guide with embedded videos. So the other thing we heard from our providers is, okay, it's great in theory, but what does it sound like? Like, what do I actually say when I'm concerned that a child is being maltreated, the parent is in the room, I know I need to talk to the child, how do I get the parent to leave? So we have little videos that actually show a clinical encounter where that happens, and little scripts. So, instead of saying this, why don't you say this? And actually give people words. So that was kind of a revelation to us that what people really wanted was at that level of helping them to do it right and showing them how to do it right. And that led to another, I think, big innovation in terms of Vega, is our game-based learning. So we're working with the Games Institute at the University of Waterloo, which is quite a famous sort of tech university in Ontario. And they develop learning games for a variety of different topics, but we've worked with them to develop learning scenarios so that providers can practice these skills in that game environment instead of on real patients, which we think is a good thing. So we have 3 scenarios. One is on intimate partner violence in the emergency department, and there's a piece where the partner is present and won't leave, so you see the nurse and the physician sort of work together to get that partner out of the room so that the conversation can happen. Another is in family practice, and it involves intimate partner violence as well as children's exposure to intimate partner violence, so you see the interplay of that. And the third is child maltreatment specific. I think it's in a dental setting, I recall correctly. We've gone back and forth on that one. But then also videos. So we've got midwives involved. So we have a video of a midwife interacting with a woman around the, just before she's to give birth, and sort of starting to identify that something might not be right, that things might not be safe. So those sorts of videos and tools and templates. So you can download a template that helps you create your own documentation form with documentation do's and don'ts. We think is sort of a quite a solid package to help people learn how to do this and then practice those skills through the game, so that when they actually get to the point of interacting with a live person, they can see what the impacts of their style and their interaction approach will have. So the game will actually take you, if you go down a bad path, you see a bad outcome, and then you get to try again and pick a better path until you get to the outcome that you'd like to see based on what you've learned in the e-modules. So that added, I think that's probably what added about a year to the project, was the game development, and we didn't know we'd all become script writers. You write a lot of scripts for videos and for games and so on, which is different than most of the research work that we do, but quite exciting. So that is the overall Vega package, and the idea being that it's tailorable and really skills-based. So now, we've got a foundational package, but the nurses will take it and want to tailor it in ways that are relevant for nurses. The dental hygienists will want to do the same. And we've spent a lot of time going to different national conferences and talking about Vega to sort of get people ready to take up these things. So, I did want to mention the example about how we integrated what I call trauma and violence-informed care, that creating safety, and these principles that I talked about, and building on good work already done. So as many of you, I'm sure, are aware, the World Health Organization talks about the LIVES approach: listen, inquire, validate, enhance safety, and support. So the tools and videos and all of these things that I've mentioned actually integrate these principles of trauma and violence-informed care, that the bubbles in the middle, into the LIVES approach. So we've adapted LIVES to make sure that it talks about creating safety. So what does it look like to inquire about needs and concerns if you're taking a perspective that includes more structural violence, for example, or the sort of conditions of people's lives that might be marginalizing them? So that again, I think of this as the neatest innovation in Vega, although people who like the tech stuff think that the game-based learning is pretty neat. So they're probably both pretty neat. So we're just coming to the end of the development process. So by the end of this month, the materials will be ready in English for soft launch to our national committee members. So in Canada, we're a bilingual country, so we can't do a public release until everything's been translated into French. So we'll have the English ready by the end of June, and then it gets translated for an official launch, probably after our federal election, because the government can announce things when they're in the election period. You might have the same thing here. So probably sometime later in October or early November would be the public launch of these materials. But as of the end of this month, our partners will have access to the materials, so they can start to think about how to tailor, adapt, and integrate into their various systems. So the Public Health Agency, again, the importance of having this partner with us all the way, they have provided additional funding to those organizations to do the adaptation projects. So they call it Vega 2.0. I'm still trying to get through Vega 1.0. But our partners are now starting to think about ways to do that work with additional funding from the Public Health Agency of Canada. We also in Canada have a federal gender-based violence strategy through our formerly Status of Women Canada, which is a federal department, but they've recently changed their name to Women and Gender Equality Canada. So they work closely with Public Health Agency and other departments around issues of gender-based violence and family violence, and have launched what they call the Knowledge Center. So feel free to take a photo of that slide if you want to visit any of those materials, but I think there's some neat sort of innovative work happening at our federal government level, which is interesting because health and social services are actually delivered through funding at the provincial level, but it's the feds that are sort of leading this, but we can talk politics later. So this is the site for the GBV strategy, and then the Gender-Based Violence Knowledge Center. So there might be some useful resources if you want to visit those sites. Okay, photo's done. So 2 more slides, we're almost to the end. So I just wanted to share some lessons learned around this, and I've sort of tried to intersperse them through. But really it is about building partnerships and building on partnerships. As I mentioned, this really, if I think back, started with work that we did in the mid-2000s, just trying to see if these expectations that everybody seemed to have of the healthcare system were realistic. And then, doing that research that found these are not realistic expectations, and having a conversation with a policy person who then was able to write a briefing note that got a minister interested to sort of make this a priority. So that notion of partnership, and I wrote a paper called Talk, Trust, and Time, but it's talk and listen, but the 3 T's sounded better, so I took the L out. It does, take a lot of talking to develop the trust, and it takes time. I think in the evidence-based medicine literature, it's like 17 years before an innovation actually gets, taken up into practice, a clinical innovation. I'm not sure if it's 17 years in this case, but it's been a good 10 or 15 almost, hasn't it? So maybe we're getting on to close to 17 years. And then this notion of buy-in and support, right? So having those folks come to all of our meetings over the last 4 years, and in some cases, they're very tiny organizations that don't have a lot of resources, so their leaders come. In other cases, it's the Canadian Medical Association, which is a massive organization, so they'll send a delegate, maybe a board member or a staff member. So a mix of people with different authority to make decisions, but they come, and they kept coming back and doing the work. So really, it's about how to keep people engaged in this work, especially when most of these folks, this is not their everyday stuff. I mean, Child Welfare League, yes, and Women's Shelters Canada, yes, but all those other organizations, they're doing this because they know that this is a big, wicked problem, and they need to be at the table. So we really worked hard to make the meetings interesting, sometimes fun, useful for them, so they were learning, but they also were meaningfully contributing, and they saw it that way, that what they provided to us became part of what was produced rather than just tokenistic, chatter, and very outcome focused. Working across professions. So if we did small group work, you weren't allowed to sit with all your nurses. We sort of mixed people up to think about what does a pathway from the triage nurse through to the whole interaction and emergency and then out to a referral. What does that look like, and how do we reflect that in our clinical pathways and some of the other tools that we developed? And really thinking about knowledge mobilization, helping those organizations plan how they were going to do the convincing up to their leadership and down to their membership. So working with them to develop those knowledge mobilization plans and thinking about scale up, and then having Public Health Agency actually provide the funding was a big deal. And then, that policy buy-in and support. In this case, it was the funder, was the policy body, the Public Health Agency, all the way up to the president of Public Health Agency and the health minister, meeting with us at various points in time, knowing about the project, their staff, that coming to our meetings and then briefing up. These were very important levers that kept this in the imagination of government. So they made the initial commitment, but they kept coming back and having a presence, and then providing new commitment for evaluation and scale up. And evaluation is very important, so we've also created an evaluation logic model, because we do want to see if this makes a difference. And then, so if you get funding to adapt, you also have to evaluate, and we give you the logic model, and then you collect data to see if you're actually changing important outcomes. And again, my last slide is around paying it forward. So what would I tell people if they were engaging in this work? This is the one I was thinking about. You've done a lot of this work in Victoria, so maybe you can think about these things and pay it forward to the next folks. But really developing what I think of as a basis of unity. It's more than terms of reference, like that you would have at a committee. It's really finding the common ground of your values and why you're doing this work together, and then reminding yourself, because there will always be points of tension when people don't agree on specific actions or on approaches. But having that basis of unity means you can work your way through those moments and find that point of consensus to get the work done. So that's when I talk about true co-production of knowledge. It starts with a common set of articulated values and works from there. And those are what lead to those pathways for uptake and impact. And again, I think it is not unreasonable to say that in some cases the evidence-based medicine phenomenon has seemed very top-down. And, research evidence seems to be privileged above other forms of knowledge. And we had to sort of break out of that way of thinking and really understand that you need everyone's knowledge, skills, social capital, their networks, whatever they could bring to the table to get this work done. And I think that is the nature of wicked problems, that it does need this all hands on deck approach, if you will. And not everyone stays engaged. Roles change. This is what I found over about 15 years of doing knowledge mobilization work. That partner who's so engaged then gets another job somewhere else, and now you have a new person that knows nothing. So you have to work with that. It's just the nature of doing this. And often you find the new person brings something really neat, and you never lose the old person. Always keep, wherever they go, keep them, and they're still a contact. They become part of that social network or that social capital. And again, expect disruption and misalignment, and just work through it. This is expected. That's, I think, a key message, that this work, it's iterative, it's complex, and it will disrupt the way people think about things. And that's okay, that's good, actually, because you're not going to change anything if you don't disrupt people's thinking. Right? But you have to give them time and space to come to the new way of thinking, not go, start wagging your finger because they haven't figured it out in the first 30 seconds. So work through those blockages. And for sure, it's like renovating a house. It will cost more and take longer than you think. This integrated, this true authentic partnership piece, requires additional care and feeding. It does take a lot more work. But if you don't do it, you don't end up with something that people will take on and embed, because now our job is almost done. It is now time for the organizations to decide how this will live forward into curricula, into continuing professional education, into hospital and other policies and systems, right? We can't affect that anymore. Now that work has to be done by them. So that is what I had. That's the beautiful building that I work in. All right, and I'm early. I think I'm a little early. So time for questions. Do we have questions? Yeah, would you like to ask questions? I think I am a little bit early. We started a bit early. Yes.
Hi, Lauren Varma from Royal Women's Hospital. Thank you, Nadine. That was a great presentation. Thanks. So good to see so many commonalities between our Shriv work. But the key thing was around competency-based learning. Mm-hmm. And I was just curious how, particularly if it's an online platform, what assessments staff would have to undertake to become competent.
Yeah, no, that's a great question, Laura. Thank you. So in the e-learning modules, there will be sort of quizzes and other points at which you have to demonstrate that you have mastered either the knowledge or skill through the game, for example, of that particular part of the module. And once you've completed everything, you get a certificate of completion. Now, again, that's sort of the foundational common platform. It might be that, for undergraduate nursing education, there's a much more enhanced approach to that would involve role play and other things if it's in a classroom setting. So we've produced sort of a foundational approach, including built-in quizzes, knowledge checks. Also, we do things like, check your own assumptions at this point. Tools like, well, I call it the empathy tool, but I'm not allowed to call it that. Journeys to safety. So understanding, it's actually a high-level qualitative metasynthesis from the intimate partner violence literature about, why she won't leave, that sort of myth, and helping understand that it's a process. And that there's always risk along the way to disclosing and so on. So all of those tools are built in to help people give the context of what they're working with here, a bit of empathy, and then check their knowledge and their assumptions and biases as they go through. So that's the approach in the e-learning modules. Yeah. Kelsey.
Thanks. Can we talk about money? Could you say how much
the
initiative cost, and also, although we have had some investment in the health sector, we've had much less than the justice sector and otherwise, and what you think the key things were, other than you having a chat with someone at the Public Health Agency, as to how you've leveraged more funding, because Shriv's going to be getting less and less funding over time.
So this project was funded for $4.5 million over originally 3 years, and then we got some no-cost extensions. I think we got additional money. So originally we thought that the platform would be housed at the Public Health Agency of Canada, that these online materials would be, and then they told us partway through, oh no, we can't do that. Well, that was a bit of a shock. So they will be housed, actually, my colleague Harriet McMillan, co-lead of the project, will house it at McMaster University. So there was a bit of additional funding just on the technical piece, but it was $4.5 million was the initial investment, and I believe they have $600,000 or $700,000 for some of these follow-on activities for the development of the curriculum and then the integration by the organizations.
And lessons on advocacy?
Boy, you know, I think it is about leveraging all of those partnerships, who you know, and then aligning your interests with their interests. So right now you have a lot of attention to this issue in Victoria. You know, bring the data, bring the evidence that you have to show this is a health issue. You know, I think our statistics are similar. In Canada, it's 1 woman every 6 days is killed by a current or former partner. I think your minister said 1 a week here, and it's been accelerating lately, same as in Canada. So that's a pretty serious health issue when you're talking about actual death. So show the costs and why it's important. We have been lucky that the Public Health Agency, and in particular that minister, saw this as a health issue. I remember her remarking to me when she was Environment Minister, there wasn't much she could do about violence against women, but as soon as she became Health Minister, her first major address was to the Canadian Medical Association on family violence. So find your champions. I know it's as simple and as difficult as that. At the back, yeah.
Sorry, can you just put your hand up again?
I just wanted to raise the issue of elder abuse. You haven't talked about elder abuse in terms of your project at all. What we're seeing in terms of elder abuse is that some of it is actually intimate partner violence occurring with people that are older, but sometimes you've got current child abuse, intimate partner violence, and abuse of an older person. There are some differences, but there are also some similarities. So I'm concerned about it not being part of your
absolutely.
framework. And
dating violence isn't either. So forms of IPV between non-married younger folks, or I guess dating couples of any age, absolutely. And you know, again, when trying to scope something like this, in some ways, the Public Health Agency made those decisions because that was not in scope. But what I would hope is, as people start to take this up and adapt and tailor, that we start to add more modules. So I've talked with some of our Indigenous organizations. I think that this provides some good basic content, but you know, would not be appropriate for a holistic model of health and well-being, as you know, our Indigenous partners would want to have it, a more family-oriented way where both victims and perpetrators are part of the unit of assessment and intervention, right? And sort of the more Western models are not really taking that approach. It's still very individual, victim, perpetrator, and so on. So my hope is that we start to add on more modules now that we have an approach, hopefully an effective approach. Again, we don't know yet if it's effective. We're certainly hoping it's effective. It shows promise. People are excited. But that more work needs to be done. I have no idea how this will be updated, for example. Kelsey will do a great trial and it'll change the whole world of evidence, and then that will have to be sorted out. But it is really now to the point where we hand it on, and people who find they need to do new important things figure out how to build it. And I also worked with an organization that looks at LGBTQI2S populations, and how do we have specialized understanding and training for those folks linked to the Vega basic curriculum. So there's still work to do. I just have to rest for a while before we sort of take it on.
Hi Nadine, thank you for that fabulous presentation. I do have one question around the e-learning, another one around the e-learning. With regards to the recognising and responding, I think we refer to that one as identifying and responding, similar. Did you, in the development of that, or thinking about the development of that, have any kind of concerns or resistance raised around safety in terms of, because we know the prevalence of family violence is so high, and that potentially from the work that Kelsey and the team at the University of Melbourne did, we know that the prevalence potentially amongst health professionals is potentially even higher than the community. Were there concerns about the safety of doing e-learning for health professionals in terms of the risks of triggering people's experiences, and what safety nets might need to be in place for that?
Yeah, no, that's a great question. We talk a little bit in the vicarious trauma part of the Creating Safety module around, for example, nurses have a higher prevalence of IPV than other members of the general population. So that piece of self-care and help seeking around that. In terms of, and I'm not sure I've understood your question, but if people are doing e-learning in the workplace, is that what you mean? And actually, maybe leaving a computer open and somebody else seeing it. I think that's actually up to the organizations and the settings to put those safeguards into place, because I'm not sure what a standard approach would be other than very high level, messages like make sure to log out and don't leave your browser window open, that sort of thing. But the emotional safety.
Safety of the person. If they've personally experienced family violence, is the content going to be triggering? And because that's the concern here, and part of the reason why at the moment we deliver that face-to-face, to provide that safety at the end of the training if people are triggered and upset and need to leave. And
right. Yeah.
Yep.
Yeah. So that again, it's part of the Creating Safety module, and specifically in the vicarious trauma submodule, probably not addressed as fulsomely as it should be, but I'm not sure exactly how to do it. So maybe it'd be great to chat and see how you've done it here. Yeah.
Maybe just one more question.
Hi Nadine, I'm Trish from the Women's. I'm just interested in, I guess, Canadian experiences with Vega and the kind of gendered violence message and the kickback that health professionals might have had and maybe the compromises you might have had to make around, that is a really tricky message to deliver, and that's the one where you get a lot of pushback, yet it's so important to understand it as a determinant of violence and gender equity.
You had to leave me with that one at the end.
Sorry.
Just
answer it in 1 minute.
Yeah. Can I use the jet lag card on that one? So we, as I mentioned, have these contextualizing messages through the curriculum, and one of them is the role of gender. And we also try to specify when the research or the guidance is arising from research based on women's experiences, we're very clear about that. However, we do take the overarching principle that all genders are experiencing these forms of violence, and it's important to recognize that. We have guidance, and again, based on the work of Kelsey and Angela Taft and Jean Fetter, on how to interact with perpetrators, especially if they're both part of your practice or service. So we've tried to build those things in. I feel very strongly that we have to keep the gender lens very much up front. So to the extent I've been able, I have those contextualizing messages. And I think most members of our national committee also find that an important value. And then also understanding that with children, you do have gender differences, but it might not be gender-based violence. It's about different forms of power operating. That's my personal observation. But we know that boys and girls will experience different forms of maltreatment at different rates with different impacts. So we do try to make sure that those messages are embedded throughout. And, if anything, our national committee members asked for more context to help them understand why the guidance looks the way it does. So I think that's a good sign. They wanted more context around all of those vulnerabilities and marginalizing conditions that I mentioned earlier. And then it's a balance between how much content can you expect people to get through, what's crucial, and so on. So finding that right balance. In some ways, that's been the biggest challenge, is finding the right balance. And I always say to my medical colleagues, we cannot make this based on a third-year residence schedule and ability to be able to get through this material. We want to make sure that the right stuff is there and there's enough of it. That said, make some things optional. So if you've got more time, you might be able to watch a couple of videos. If you don't have to watch the videos to get through. So those are the little minute decisions, along with script writing, that just take an extraordinary amount of time, which is why year 5 of a 3-year project. Great. Thank you again, everyone.